Thank you so much, Victoria. So as Victoria said, we have three fabulous speakers tonight. One of them is joining us from Victoria, Prof Rosemary Ogu, and then followed by Prof Jayashri Kulkarni, who's joining us from Melbourne in the midst of their very big lockdown. And then finally, we have Prof Ruth Stewart, who's going to be our final but not least speaker, who's the current National Rural Health Commissioner for Australia. So without further ado, I'm going to start off to introduce our first speaker, who's Professor Rosemary Ogu. She's joining us from Nigeria, as I said, where it's currently, I think, 8 a.m. Is that right? Yes.
All right.
So she's a member of the Society of Gynecology and Obstetrics of Nigeria, past president of Medical Women's Association of Nigeria. She's a professor at the University of Port Harcourt and consultant obstetrician gynecologist at the University of Port Harcourt Teaching Hospital. She has special research interests in the areas of sexual and reproductive health and non-communicable diseases. She's the secretary of the World Health Organization, Federal Ministry of Health, Maternal Newborn Child Health Implementation Research Team for the reduction of maternal and perinatal mortality in Nigeria. She's the principal investigator of the World Health Organization Safe Childbirth Checklist Collaboration in Nigeria, the NWAN Safe Childbirth Checklist Initiative for Improving Maternal Health in Sub-Saharan Africa, and the Gestational Diabetes Mellitus Control Program in the Niger Delta. As well as all these amazing achievements, there's the whole lot that I actually didn't include. She's also a mother, and so she's married with children. So without further ado, I'm going to share my screen for her presentation and take it away. Let me know whenever you want me to change the slides.
Thank you so much. It's a pleasure to be here. You all heard who I am. I'm here because I've been invited to speak. I'm here because I've met Professor Gay Kasper. I'm here because of Dr. Elinor Wadinobi, who is the current president of the MWIA, Medical Women International Association. It's a pleasure to be here to talk on maternal and child health in Nigeria, global WHO perspective in COVID-19 era. Next slide, please. And so I'm speaking to young students. Whenever you're to give a presentation, do an outline. And your outline can take several forms, but the simplest outline is to have definitions and then have conclusions, and in between, decide what you want to talk about. And that's what I've done in this slide. I'm going to talk for about 10 minutes, and so that will give us another 10 minutes to discuss, to interact, for people to ask questions, and then we'll move on. And so the next is, what is women's health? What is health? Where in the world? That's our topic for today. Where in the world? Women's health in 2020. And then how can you participate? What can you do? Why should you participate? As we move on, you should know, you would see why you should participate. And towards the end, you should see how you can participate. And then we conclude with something that we want everyone to take back. Next slide, please. And so health is a state. It's a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity. This is a 1948 definition by the World Health Organization that hasn't changed till now. It still holds. For us to be healthy, we have to be physically, mentally, and socially okay. Next slide, please. And so when we talk about women's health, we talk about the health of women. Women are unique. Women are different from men. And so when you talk about women's health, it's different from men's health. There are unique biological, social, and behavioral conditions that shape women's health. And in the same vein, that shape maternal health. And so our interaction today, we're going to focus on maternal and child health. That is the health of a woman while pregnant or within 6 weeks of childbirth. That is a unique global issue. Next slide, please. So the health of a woman while pregnant or the health of a woman within 6 weeks of childbirth has been recognized as a global priority by the World Health Organization. One fallout from maternal health is maternal mortality. That is the death of a woman while pregnant or within 6 weeks of pregnancy. And it remains a major problem in global health. And so it's not just that, oh, it's a developing health problem, or no, it's a problem for only Australians. No, it's a global issue, okay? And maternal health, maternal mortality is an event that can judge the quality of healthcare systems worldwide. Next slide, please. So what does the WHO tell us? I've done a lot of work with WHO. What do they say? I'm talking to year 1 to 4th year medical students. I have people in the audience as well who have children, who are mothers, who have adolescents. And so the fact remains that adolescent pregnancy is a particular problem, whether it's intended or unintended, whether within a marriage or a union, whether it happens unexpectedly. Adolescent pregnancy is a peculiar problem that affects all of us worldwide. And so I need this audience to know that those are part of what you can do. Next slide, please. And so what does the WHO say? How do we take care of women? How do we take care of our girls? How is COVID-19, how is the ongoing pandemic affecting maternal health? The ongoing pandemic is preventing access to maternal and reproductive health care. And so antenatal clinics, family planning, contraception, they are all negatively impacted by the pandemic. The lockdowns, you can't go out, you can't go and access care. You can't get commodities, you can't get consumables, you can't get health commodities. You can't have routine immunization. For those who have HIV, for those who care for HIV patients, you can't even have access to your patients. And so everyone has susceptibility to poor outcomes in the COVID-19 pandemic. Whether you are ill, whether you are healthy, the outcomes from this COVID pandemic impacts negatively on everyone, socially, economically, physically, mentally, the stress of COVID. So also surgeries, procedures can't be done anymore. There's a lockdown going on now in parts of Australia and people can't even go out. So if you had a procedure, you can't have it done. Same here in Nigeria. Postponement of procedures such as surgeries, routine follow-up care, all are aspects of healthcare, women's health, that have been negatively impacted by the COVID pandemic. Next slide, please. And so in all of these, when we're taking care of patients as clinicians, we look at guidelines and guidance that guide us on what to do, on what is best practices. The WHO guidance that came out told us, or makes us aware, informs us that pregnant women might be at an increased risk for severe illnesses from the COVID-19 pandemic compared to non-pregnant people. And so maternal health is further impacted. Additionally, there are increased risk of adverse pregnancy outcomes. Next slide, please. And so you may have preterm births among pregnant women with COVID-19. Although we don't know how it impacts on newborns, but we do know that the impact is not favorable. And so to care for patients, the WHO routinely issues guidance, and these guidance are available online. They are free to access at www.who.int. Once you go there, you see the guidelines for managing every case you can think of, every health condition, especially for maternal health. And in this COVID pandemic, the WHO has issued an interim guidance for maintaining essential services during the pandemic, and includes advice to prioritize services related to reproductive health and to make efforts to avert maternal and child mortality and morbidity. And so it's there. So as clinicians, as medical students, as women, there are things that we can do. Next slide, please, to help, to ensure that we have better reproductive health outcomes. Now, that is in a global picture. When you come down to Nigeria, what are the further problems that Nigerians have? We don't have a viable, vibrant health insurance. And so out-of-pocket payments for services negatively impacts on health, because the patient has to pay for any services that they need. And you can imagine what that means. It's very difficult. There's poverty as well. And so even for those who want to utilize health facilities, they are not able to because they can't afford it. Sometimes there's ignorance too, where you don't even know what you're supposed to do. Next slide. So poor quality of care when you eventually get to the facilities. But then before you get to the facility, lack of electricity, water, roads, infrastructure, equipment, all those are further problems that you have with maternal and child health in Nigeria. Next slide, please. And so you take the presence of a light bulb as a norm, but it's not like that. You can be in a health facility where there's no electricity. And so irrespective of your skills and your knowledge, there may be not much that you can do. And so what have I done? What have I done as Rosemary Ogu? What have I done working with the WHO? We've assessed the impact of interventions that improve emergency obstetric care or maternal and perinatal outcome in Nigeria. We've done that. So between 2012 and this 2020, we've done a lot of work and we have had a lot of papers published where we've tried to find out women's satisfaction with maternal health care in referral hospitals, where we've tried to find out what endangers the attainment of the SDGs in Africa, where we've tried to find out how do we overcome the social cultural factors that contribute to maternal mortality, and so on and so on. So in the respect of working with WHO, this is where we started from, finding out what the issues are and how we can make them better. Next slide, please. And then after finding out what the issues are, the next thing we did was to implement the safe childbirth checklist in our health facilities, and then to see the difference. When you implement the safe childbirth checklist, which is a tool developed by the WHO, the World Health Organization, to improve maternal health, especially during childbirth. Now, when you implement it, what does it show? It shows that health workers comply with best practices at that point. And that was also published in the British Journal of Obstetrics and Gynecology. Next slide, please. And so the checklist is something that I am encouraging personally, and then I ask all of you to encourage and ensure that labor units in wherever you are use the checklist to improve the services that are offered. The same thing when we talked about improving maternal health, we talk about starting from the young ones. And so even reaching out to adolescents to imbibe activities that will make them have a better maternal health. And so we mainstreamed youth-friendly health services into existing primary healthcare facilities in South Nigeria. This was sometime in 2016, and then the project completed, and then we published in 2018 in the International Journal of Adolescent Medicine and Health. And we showed that post-intervention, adolescents were willing to utilize services across board. All right, the interventions implemented increased the odds of youths utilizing youth-friendly health services 1.8 times. Next slide, please. So we've worked on finding what the problem is. We've worked on how do we enable adolescents to prevent the problems that the adults are having. And then we went on to improving maternal health, enabling access and advocacy interventions to promote diabetes prevention and improve outcomes among pregnant women. And so between 2017 and December 2019, we have so far screened 22,202 pregnant women for gestational diabetes. We've supported health facilities. We've trained healthcare workers, about 1,000 healthcare workers trained. And then we've prevented adverse outcomes in about 918 pregnant women. Next slide, please. So this improving maternal health, gestational diabetes project is something that we've been doing since 2017. We're hoping that other healthcare facilities, other collaborators can take it up in their places. We presented it in New York when we came for the meeting in New York. We presented it during the Medical Women's Biennial Conference in Asaba. We've also had publications arising from that project, and those publications are available online on PubMed. Next slide, please. And so generally, we do things to improve maternal health by looking at what the problems are, what the solutions can be, and then implementing the solutions to make changes. Next slide, please. Because our women are the backbone of societies. Women are the rearers, carers, and bearers of societies. And so this is one of the places where we were training healthcare providers, training healthcare workers. Next slide. Training healthcare workers in tertiary institutions. We've trained healthcare workers in primary healthcare facilities. We've trained in secondary healthcare facilities. We've also trained in secondary healthcare facilities. So what can you do? What can you do? How can you be part of all this? You can be kind. That's one thing. You can be compassionate. You should help where help is needed. Help can just be listening. Help can be encouraging. Help can be becoming the best at your abilities. We all have different abilities. You have books to read, you have lectures to attend, you've had a long day and yet you're still here. Thank you for being part of this. That is how you can help. You can encourage a pregnant woman, you can encourage your peers, you can help educate others. And then you can advocate for better maternal health using this platform, Global Hands. Thank you. Please keep up the good work. Using whatever platform that you have, using Australian Medical Women Federation, using the Nigerian Medical Women Association, using the Medical Women International Association platforms. All those are avenues where you can use to advocate for maternal health. And so in conclusion, what have we said today? Next slide, please. We've said that maternal health is global health, it's population health. We've said that healthcare providers' knowledge and skills affect maternal health. We've said that antenatal care and health education are critical for maternal health. We also know that socioeconomic and behavioral conditions critically affect maternal health. Do your part, do your bit. Thank you for this. I can take questions if I still have time. Thank you. Final
Thank you very much. Thank you very much, Prof Ogu. That was very inspiring and informative. Yes, you do have time for questions. We have 10-15 minutes. I'll start off, I guess, before we get along. I can ask people to either type it in the chat or ask directly. So I'll ask the first one. What do you see as what is the current largest cause of maternal mortality worldwide, seeing as it's been recognized as one of the WHO priorities?
What is the
major cause of mortality in the maternal population?
Oh, worldwide it's postpartum hemorrhage. Women bleed after childbirth. So that is the commonest reason why they bleed. About 25%, 1 in 4 pregnant women who die do so because of postpartum hemorrhage worldwide. But in Nigeria, it's the other way. 23% is postpartum hemorrhage, and about 24-25% is eclampsia, severe preeclampsia. So complications arising from hypertension.
Okay, thank you very much. Do we have any questions from the audience?
I have one if no one else does. Thank you, Prof Ogu. That was really interesting to hear. Just for a question, you've obviously done a lot of research into this area, and I just wondered whether you would give any tips to any of the students interested in the audience who might be looking at doing some research in this area, and sort of how to focus or maybe find sort of areas of interest or what is needed in respect of this on a global scale.
Okay, for students, first things first, have the background. Have the background means read your books, go attend your lectures, try to study. and then have the mindset to want to improve things, to want to make things better. Everything can be improved. No matter how good something is, you can always make it better. And so if you want to go into research, follow your heart, do things that are interesting to you. That way you don't call it a task. That way it's not so difficult. If you're doing something that's not interesting to you, and it becomes very drudgy, very difficult, it's not exciting at all. All these things I've done, people ask, how did you do them? You're doing so much. It's interesting for me. It's something I love doing. I love helping out. And so you need to have that as one. And then there are courses that you can take. There are ways to know how to carry out research. You can do those courses. Most of those courses are online. Some of them are free. Then what else? Another thing that you can do is if you select something that you say you want to do. Let's say, for instance, you want to find out why women are dying from postpartum hemorrhage, or you want to help to prevent women from dying from postpartum hemorrhage. It's now just look at the patients who come into your facility with postpartum hemorrhage and then study them. Studying them means maybe just taking a little bit extra care to look at what is happening. Then you notice that, oh, most of them missed their oxytocin. They didn't receive the oxytocin when they were supposed to receive it. That's research. So you, by observation, you notice, you find out something, and then you now take steps to change it. The beauty of research is, yes, you can find out what the problem is, but you can also use research to make the solution. And so as students who are coming up, have it at the back of your mind that you can do a lot. You can do a lot as students. And so you go on, you observe, be observant, look at what is happening. Ask yourself questions. Is this the best that we can do? Can we do better? If we want to do better, how do we do it better? And then that's it.
Thank you.
I've got two questions. My first one is, I already know the answer to this, but I'm sure the students would be interested. In Australia, a patient comes into the room, we chat about what to do, she makes her mind up what she wants, and she goes and does it. But in your hospital, what is the role of the husband? Can a woman just come in, determine the whole of her fate, organise all her management and walk away? Or does her husband need to be involved in decision making? That's question one.
Yeah, so that's where I talked about behavioral conditions affecting maternal health. In Nigeria, most women would want the husband to take the decision for them. And so even when you're telling a woman, look, you need to do this, you need to have the cesarean section now because of fetal distress. It's not something that can wait. You can't wait. This baby's fetal heart sounds, it's 180 beats. We need to go in and do something. Or we're having fetal bradycardia. Fetal heart rate is 100. And the woman tells you, no, wait, my husband has to come and take the decision. Or no, wait, my pastor has to come and take this decision. So those behavioral conditions are still affecting us negatively. Thank you, Gay, for the question. What is the next one?
That, I'm aware that there's very little money for resources in your hospital. Last time I spoke with you, you didn't even have any COVID testing kits. So if you can't even test, you don't even know how much COVID there is. But purely from an obstetrics and gynae point of view, I know that you've got an ultrasound machine and you've got a Doppler machine, but what are the other things that you need in O&G? What are the supplies or the machines that you need that could make you have a better outcome with your women?
Thank you for the question.
Students don't,
we don't have basic.
When you walk into your delivery suite and your antenatal suite, what would they see? I know what they will see in our very rich, expensive hospitals full of technology and full of medication. But with your eyes, what do they see in your antenatal clinic? What do they see in your theatres, in your labour ward? What is it you want to burst into tears because you don't have?
Everything. No, not everything. Something about healthcare is with your skills, you can do a lot. But also without equipment, there's still a lot you can't do. right now we're not doing amniocentesis, we're not doing colonic villus sampling, we're not doing we're not doing fetal blood transfusion, we're not doing fetal surgeries, we're not doing any of all those because we don't have equipment for it. So those things we don't do. If you enter into our labor ward, you will see our delivery beds, you will see our ultrasound scanning machine, you will see basically that's it. And we go on and we do what we can. But if we can get more equipment, if we can get more things, we're just developing a plan for my hospital where we want to be in the next 5 years. I will say, look, we need to start doing coronary villus sampling. We need to start doing amniocentesis. We need to start doing intrauterine surgeries. Those are things that are done. Those are things that you can do. Those are things that you can do to improve outcomes. We need to start doing them. In terms of postpartum hemorrhage, we now have carbetocin. Carbetocin contracts the uterus and stops bleeding. It's like magic. But carbetocin costs 15,000 naira. That is almost 1 month's salary for someone. And so you tell a lady that bring 1 month's salary and buy a drug that will prevent hemorrhage, and she tells you, is there nothing else you can do? Isn't there another way? And so you have commodities that you know would work, but they are expensive. So those are the things that we see, those are the things that we contend with, and we find whatever ways that we can. So if people can help, if people can support, if agencies can come, if donors can come, it's fine. If they can't come, we need to do the best that we can. We need to make sure our women don't die, whatever the reason. We forge ahead. I know that education helps. I know that talking about it helps. I know that this kind of presentations help. And I'm looking forward to getting more out of today. I know that by the time I go back to work later today, something positive will come. Somebody could just say, oh, I listened to you. I saw you. Okay, I want to buy carbetocin for 100 patients. It has happened before, and it can happen. You know, we went to the WHO guy, and we got ultrasound machines. 40 ultrasound machines came back to Nigeria. So things happen. Medical women, we do things. So we keep it up and we continue. Thank you.
President, would you say what one thing you need is money for drugs for to prevent postpartum hemorrhage? That would be one of your #1 priorities.
Yes.
Yeah. Okay.
Thank you very much for that, Prof. And it's very eye-opening when we do hear these things. And then we also take for granted the stuff that we have here in Australia, particularly those drugs and the CVS and the amniocentesis, which is something that we have all available at our hands. We have a couple extra questions. So we have one from Ashley. Do you want to go ahead and ask yours?
Sure. Hello. Thank you. My question is, what kind of education about women's health is included in school curricula, if any at all, in Nigeria and other sub-Saharan countries that you're aware of?
In the school curricula, there's, as part of obstetrics and gynecology lecture, there's a lecture on women's health. But you know, women's health evolves. And so maybe when I was in school, what I knew about women's health was prevent violence against women, you know? And then you come now to see that women's health is a whole lot. So it's there in the curriculum, but as things change, as women change, their behavior, their mental status, their socio-economic status affects what they do. And so you have a woman who has finished university, who you think is knowledgeable, who you think is not an illiterate, behave in a way that you expect an illiterate to behave. And so your curricula sometimes may not prepare you for that because you're seeing things that you don't expect, but they are happening. And so it is when you're on ground practicing that you now see these things. All right. So in the curriculum, the medical school curricula, women's health is there as part of obstetrics and gynecology. Women's health is there as part of public health. So you would see them in the undergraduate curricula. But it may not be enough, because what happens on ground sometimes is a bit different from what is in the curricula because of the peculiar, unique behaviors of women. Does that answer your question?
Yes, I was actually intending to ask about, I did, thank you. I was actually asking about school as in primary and high school, whether there's any education to the younger children.
In primary school, I know we did a curriculum once. There was something we did with Ford Foundation. And I know there's women's health in primary school. There's maternal health, there's family life education. It's called family life education in Nigeria. So there's something about it in primary school. There's something about it in secondary school. So it's there, but how does it play out later in life? I don't know, but I know that in the school curricula, at least from when I worked with Ford Foundation, there's family life education in our primary school curriculum and in the secondary school curriculum for Nigeria.
Thanks so much.
Thank you. I think we might have time for one last question. Dr. Boris, did you have one? I saw you raised your hand earlier. No.
Okay, Rosemary, could you tell us a little bit about where you're up to with traditional cultural practices and how they affect women in Nigeria?
Oh, that's a big one.
I know, but you're
that's
good.
A big one.
I want to hear everything.
What? Yes, I know what I mean. It's traditional cultural practices to play a big role.
Yeah.
You have women with eclampsia who are fitting away and they're tied at home and there's a spoon in their mouth trying to say that spoon will stop the fit, because eclampsia is an evil thing, evil manifestation. And then you have another traditional practice where you have a woman who's bleeding after delivery, and the woman herself tells you, I am bleeding because every wife in our family dies during childbirth from bleeding, so it's my portion. You also have traditional practices where women are in labor at homes, cannot deliver, are obstructed, and they say, no, leave her there, she will deliver if she's a good person. If she's not a good person, she will not deliver. What has good got to do with the size of the pelvis? So there are lots of traditional practices where women go. You have a woman with a transverse line at term who's supposed to have an emergency cesarean section or a planned cesarean delivery. And that woman is in a room and someone is trying to massage the abdomen until they rupture the uterus, because they say traditionally they can turn the baby. So there are lots of traditional practices that impact negatively on women's health. Lots of them.
Thank you. I think they're getting a flavor of your life now. It's very hard being an obstetrician and gynecologist in Nigeria compared to Australia. Wouldn't you all agree? I've got the easy job. She's got the hard job.
Thank you, but it's an interesting job and we still get a lot of joys out of it. A lot of joys. Women stay home, women still deliver, women are saved. It's beautiful. It's beautiful.
Thank you very much, Prof. Ogu.
So all you medical students, please keep it up and then become obstetricians if you can. And then come and work in Nigeria too. Come and do 1 year in Nigeria.
That would definitely be a great opportunity. I'm sure you've had a lot of people to definitely take you up on that. So there's, we've got more than 60 people listening to you.
That's
here, so
nice.
Yes. Alrighty.
Nice.
Thank you very much. I'm now going to introduce our next speaker. And you've got a whole lot of thanks in the comments you can read through now that you've finished your talk, as I introduce our next speaker, who is, I think, a great way to follow along, because this is now going to look onto that mental health side, which I'm sure Prof Kulkarni has picked up some points during Prof Ogu's talk to bring along. So I'll just introduce her before she starts. So Prof Jayashri Kulkarni commenced her appointment as Professor of Psychiatry at the Alfred and Monash University in 2002. She founded and directs the Monash Alfred Psychiatry Research Centre, which is a large group dedicated to discovering new treatments, new understanding, and new services for people with a range of mental illnesses. Prof Kulkarni graduated in medicine from Monash University and became a fellow of the College of Psychiatrists in 1989. She has conducted groundbreaking clinical research since then and is internationally acknowledged as leader in the field of women's mental health, in particular for her innovative work on reproductive hormones and mental illnesses. Prof Kulkarni received an Order of Australia Medal in 2019 for her services to psychiatry. So it was with great pleasure that I present to you, Prof Kulkarni.
Thank you very much, and thank you, Rosemary. I really enjoyed and appreciate your wonderful presentation. So obviously this is going to be a very different change in pace. So let me just begin by sharing the screen with you. I will take a very much more Australian point of view. I am very pleased to be here with colleagues from all around the world, and I am particularly envious of my Sydney colleagues who are able to go to cafes and restaurants, unlike what we are doing here in Melbourne. The title of my topic is Women's Mental Health, Not a Priority, Not Good Enough, and I will explain why I've taken this rather aggressive approach. Mental health policy in Australia does not consider women's mental health across the life course. This is a statement from a research statement from Maria Duggan and colleagues. It is borne out in that women's mental health is not an independent or individual group of or area of mental health. And there's a lot of statements that I think are very true, which is that there is no health without mental health. It was my great pleasure and privilege to have just recently stepped down as the International Association for Women's Mental Health president. So I have been able to look around the world to see what women's mental health is like in other parts of the world. And I've got to say, unfortunately, I can't point to any one particular area and say, look, they're doing it really well. But even in affluent countries like Australia and the US and UK and so on, we do find that this is an area that is overlooked in a number of different ways. So in Australia, we just launched the National Women's Health Strategy. So you'll be pleased to hear there's a good health strategy. But unfortunately, mental health got relegated in even the National Women's Health Strategy. So this led to us doing work to actually push people to invest in women's mental health. So this is where we've released several policy papers working with colleagues around the nation to try to actually highlight women's mental health. Why? Because unfortunately, mental disorders represent the leading cause of disability and the highest burden of non-fatal illnesses for women in Australia. We're not doing terribly well in that 43% of women in Australia, about 3.5 million, have experienced mental ill health at some time in their life. When we look at the figures, we find that in fact there are a number of unfortunate places where women are doing worse than men. In particular, conditions such as depression. Women are twice as likely to develop depression across the life cycle. Anorexia, bulimia, eating disorders in general are much more experienced by women. Anxiety disorders, that's actually an underestimate. The recent estimates are more like 4 times as many women than men experience anxiety disorders and post-traumatic stress disorders. The deliberate self-harm, which is the attempted suicide, is a much higher rate in women. Sorry, I'll just get back into the slideshow. The economic impact of all of this, of course, is really significant. And in Australia, the estimate is that $22 billion per year, $22 billion per year is lost in direct lost productivity due to depression and anxiety alone. And that's the direct lost productivity. So when you think about the lost earnings, the lost effective parenting of children, divorce, loss of the care of the elderly, and many other, they're the indirects. And that hasn't even been included in the $22 billion. So when we think about why do mental disorders occur in women, we need to think about it in a holistic way, which is there are social factors, biological factors and psychological factors. The social factors, beautifully highlighted in Rosemary's presentation, of course, include such things as violence. And again, the issues of domestic violence in Australia are not small. They're very, very significant, and we're seeing a lot more of that with the lockdowns and so on. That's a global phenomenon as well. But poverty is something that affects women more. We're anticipating that with the post-COVID economic recessions, that in fact women will be affected much more by this. There is already a differential in pay between men and women even in Australia. There are gender inequities in wage, as I mentioned, and that leads to gender inequities in power, and there are gender inequities in social roles. So all of these social factors and what is going on in our environment globally and locally really do have an impact on mental health. Working alongside, so these are not individual things, they're all interrelating, is the biology. So hormone impacts, in particular here I'm talking about gonadal hormone impacts, the gender differences in drug metabolism systems, brain circuitry and genetic transmission all lead to increased susceptibilities for various mental ill health. I'll talk a lot more about the gonadal hormone impacts. And psychology, there's a psychology of women, and of course we can't stereotype all women, not of course, but in general, there are different defense mechanisms that women use psychologically to cope with stress. And this means that psychiatric illnesses can appear very differently in men and women because of this. If you take, for example, deliberate self-harm, this is an internalized response to stress, to anxiety, to a self-hatred, to poor self-esteem, that women utilize self-harm. So they will lacerate their wrists, or they will try and burn themselves or do other things to themselves. That is much more a female approach, whereas a male approach is much more outward aggression. So go punch somebody or cause a fight or break something or destroy property. So that's an externalization of stress response. So let me talk a bit more about biological impacts on women's mental health. So one of the things that I have been studying for many years now and worked on is the impact of estrogens, progesterones and androgens in the CNS. These are all potent neurosteroids. And so for a very long time, the sense of these gonadal hormones having a brain effect was not considered. You know, there was a sense of, well, everything below the waist is below the waist, and therefore does not have an issue with what is going on in the mental state, which is completely ridiculous, because when we look at the knowledge base about steroids and the neurosteroids in particular, each one of these are potent and they significantly impact on the neurochemistry, which we know is behind the depression, anxiety, behavioral responses. such chemistry as dopamine, noradrenaline, serotonin, glutamate, acetylcholine are all significantly modulated, particularly by estrogen and progesterones and androgens. So even though our patients told us that they had noticed that at certain times of their menstrual cycle, or particularly around menopause or the postnatal group, that there was a change in mental state, sometimes really, really significant depression, significant psychotic disorders, significant anxiety disorders, the actual etiology factor, the precipitating factor, which was a shift in neural hormonal chemistry, was overlooked. And that really led to a number of women having a dreadful outcome from postnatal depression or perimenopausal or cyclical menstrual depression. So as I talked about it, we've been doing a lot of work in these different areas. So PMS, PMDD, they are on a spectrum. So PMS is the milder form, with particularly in the classical 1 week to 10 days prior to menstruating, that women describe increased fluid retention. And these are usually physical symptoms: headache, breast tenderness, even pitting edema in the periphery, and so on, irritability. But that's about it. It's not really going to impact grossly on her functioning. Right through to the other end, which is PMDD, premenstrual dysphoric disorder, a hugely incapacitating, severe depression that occurs on a cyclical basis and may not necessarily coincide with the 1 week pre-menstruation. Why? Because there is a gonadal hormonal fluctuation in the CNS, which is not exactly in sync with the gonadal fluctuations in the ovaries. And so you have a lag. And so some women who are very vulnerable to shifts in their CNS hormone fluctuation and responses will present sometimes just post-ovulation, sometimes even a little bit later than that, with problems of depression, significant depression. And they get dismissed as, you're just making this up, you're just putting this on, go away. Or they get treated with mega doses of SSRIs and antidepressants and even ECT and so on. Or they go at the age of 25, was the last patient I saw last week, who had a total hysterectomy and ovarectomy because she had significant PMDD. And the concept was, if you rip out all the reproductive organs, then this will all get better. So of course not. This is a brain condition. We can't rip out her brain, but it was this thinking that, and it's not an uncommon phenomenon, and it gets worse when the woman is in her 40s, for example. I'm going to talk as much as I can about some of these areas with more details. I don't know if I'll get through all of this. It was a bit of an ambitious agenda. So PMDD, I've mentioned quite a bit, but it is a real entity. And about 10 to 15% of the population have been described as having PMDD. And as I've mentioned, it doesn't necessarily follow a clear premenstrual pattern, but it does have a cyclical pattern. So in our clinic, we look very much for the story of the woman who says, every month, or roughly every month, suddenly, and it's the rapid onset and offset you look for, suddenly, and she'll click her fingers or clap her hands, I feel I just can't do anything. I can't get out of bed. I can't think. I get brain fog, I can't do anything, and I feel awful, or I just can't stop crying, etc. And it comes on suddenly, and there is a sudden offset, often with bleeding, menstrual bleeding, but it can be at other times. But it's the sudden onset, sudden offset. That is not how depression, typical depression presents. That is a gradual phenomenon, and it doesn't stop suddenly. So, she's telling us, hey, there's a switch in my brain that has gone on and then gone off. And when we think about that, what she's actually saying is, this is a biological something has gone wrong here. And that's why she has this particular condition, very different to standard depression. So for severe PMDD, not the PMS and not other psychiatric conditions, we cannot treat this group with vitamins and herbal treatments and lifestyle. You can tell this woman to exercise and to lose weight and be healthy and eat well and all those things. We tell all our patients that anyway, but it's not going to help with the specific symptoms that she's experiencing. in this instance, what is really critical is to be very simple. This problem is created, perpetuated, precipitated by a hormonal fluctuation in the gonadal fluctuation in her cycle. Therefore, let's try and control the cycle, because by doing that, what we do is we're decreasing the major fluctuations in her cycle. In a reproductive age woman, the easiest way to do that is with the oral contraceptive pill, particularly the combined oral contraceptive pill. And now I have cut this bit short because I'm trying to rush through, but I have a whole other talk on what doesn't work. And we have a number of noxious pills on the market, noxious in terms of brains, in terms of depression. There's a whole lot of work that we've done now looking at the metabolite of progesterone, which is allopregnanolone. Allopregnanolone is a particularly tricky customer in the brain because too much allopregnanolone, in between doses of allopregnanolone can cause a depression where there was none before. And many of the pills that we have on our market have that medium dose range where they're actually causing depression, which was not there before. And it is worse if you give a woman progesterone only medication. That is, you know, the Implanon, for example, which is the rod under the skin, or a Mirena IUD, or the mini pill, which is the, you know, the progesterone only pill. Why? Because estradiol is actually the antidepressant in the brain and has antipsychotic properties as well in terms of its interaction with dopaminergic, serotonergic, and other neurotransmitter systems. So with giving mini pills or giving just progesterone, you don't get the positive mental health effects of the estrogen, and you may actually create the allopregnanolone depression cycle that goes on. It's an interesting one because in very low doses, allopregnanolone can be useful in treating anxiety, and in very big doses, it can also be useful, but it's getting the dose range. And the pills that we have, the very common contraceptive pills on our market, are not very good in terms of depression. They're good at contraception, so that's good, but many times we've seen women who come into our clinic with the Implanon, which is the rod, the etonogestrel under the skin. And in fact, when you remove that, you find that her entire life changes and her depression suddenly lifts. And this is after, of course, we've taken a full history about other things that might be causing depression. You know, we're not talking about the people who have all the violence and the poverty and all sorts of horrible things going on. But I always want to stress that PMDD is a brain hormone disorder, so we cannot fix this by a total hysterectomy and oophorectomy. If there are reasons for a total hysterectomy, you know, she has a huge fibroid or there's something else going wrong, of course, that's a different condition, that's a different reason, but it shouldn't be surgical intervention for PMDD per se, because that is not going to fix the problem. It's actually going to make it worse, because now what will happen is you have an early menopause, and so all of the issues in terms of mental health get worse, particularly if she doesn't have add back estradiol and particularly estradiol, but you know, have a HRT replacement. So I'm happy to, of course, we have a number of different stage procedures, but we do like this one pill that's on the market at the moment. It's the only one that's got a nomigestrol, which is a nicer progesterone, and a natural estradiol for the brain. So this is, again, I'm talking brain biology in this condition, not so much for the contraception. Mirena IUD is interesting because we thought with an IUD, well, it's all contained in the uterus, you're not going to have too much problem here, but that's not the case, because even a little bit of the progesterone in the CNS can create the disturbance in the particularly sensitive neurocircuitry and neurosteroidal interchemistry. So again, people say, but you know, we have so many patients who have Mirena, so many patients who have the Implanon, and they don't have a problem. In fact, it's really good in the adolescent. I go back to Rosemary's comment, adolescent pregnancy is a problem. And so, you know, using Implanon or the less, you know, concerning in terms of compliance contraceptives is often used in adolescence, and not all adolescents are going to have this problem. But here is the issue. Some women are extremely vulnerable to shifts in their gonadal steroid hormones in a brain sense. We don't know exactly who those women are, although we are working on biomarkers to assist us to understand which women are sensitive. The only clinical trigger that I can give you is think about her early life. And we spend a lot of time talking, you know, we have 1.5 hour to 2 hour sessions with our patients. We have that luxury. So we take a very comprehensive history, and the women who have traumas in their early life, particularly the sexual abuse traumas in early life or other physical traumas and emotional deprivations and so on, are more likely to have an increased sensitivity in the CNS to the fluctuations of gonadal hormones. And if a woman has PMDD, you can bet that she's the one who's going to have postnatal depression. And if she has postnatal depression, you can bet that she's going to have the worst menopause. So it's like there's a hormone thread that runs through her life. So taking a good history is always a good idea in clinical medicine. I just wanted to talk about depression and the pill a little bit because I did allude to it, but discontinuation of the hormonal contraceptive due to mood side effects is extremely common, and we don't tend to ask women who are on the pill, like, what is going on in terms of their mental state. So as I mentioned, and this is a really good study that Skovlund did in using the Danish register system, so it's millions of women. We've done RCTs. So our randomized clinical trials are, of course, smaller in number, but we all agree on what I've just talked about, that in fact the progestogen in the pill is the culprit, and also that some pills are worse than others for creating depression. And we only at the moment in Australia on our market have one mood neutral pill, trade name Zoli. So that's really sad that after so much time has elapsed, that in fact the pill manufacturers have not taken mental health into consideration when they've done their clinical trials and looked at the adverse events coming out, as we do in all of our clinical trials. Perimenopausal depression, I wanted to quickly talk about. How am I going for time, Samira?
A couple of minutes.
Okay. I'll quickly wrap this up. But I've sort of been talking about it as we go on.
Yes.
But this is a high risk group for the development of clinical depression. The unfortunate statistics in Australia and worldwide are that there is a significant proportion of women who actually commit suicide between 43 and 52 years of age. There is a 16-fold increase in depression in this age group, and that's the Harvard Mood Cycle study. And our ABS, Australian Bureau of Statistics data, bears out that middle-aged women are the second biggest group who commit suicide. The biggest group in Australia are elderly men over 85. Now, that is usually a surprise to most people because we've been fed the story that it's the young people who commit suicide. Not at all. Look at the data. It's the middle-aged women who are the fastest growing group, and they're the second biggest group who commit suicide, which is dreadful. And we think that it's this factor, the menopause, perimenopause, that's actually playing out badly here. So again, the declining chaotic HPG axis functioning between the ages of 43 and 55. And again, the CNS is occurring first before the actual hot flushes, the amenorrhea in the body. But in the CNS, up to 5 years beforehand, there are significant fluctuations in the, if we like to call it, the HP axis part of the HPG axis, the hypothalamic pituitary part of that, as you can see, is in the brain. So this is happening well before, which makes it a diagnostic horrible situation, because often women present at 43 saying something is wrong. I'm feeling depressed every so often, and I don't understand what's going on. I've never been depressed before. This is first time ever depression, or in fact relapse of existing past well-treated depression. So here are the common symptoms that we see in depression in the perimenopause. I can give you these slides so you can distribute them to your colleagues, but this is a rating scale that I've developed to look at perimenopausal depression. And again, it's the same story. A subset of women are predisposed. I'm not trying to medicalize menopause. Many women, you know, it's not something you can outsource. Every woman is going to undergo menopause. So you can't avoid it. And of course, not every woman has a hard time. Many women just say, oh, you know, I don't even remember. But a subset of women seem to be predisposed to experience severe depression because of the hormonal fluctuations. It is not something that she has control over particularly. It comes in women who have had very nice, you know, social context, no particular problems. They're very happy. They're usually very positive. You know, it just is something that happens, and it cannot be estimated. Perimenopause cannot be estimated with our usual laboratory investigations because this is a brain estradiol fluctuation in particular, and we can't measure that unless we do PET scans and so on. And then we have these management dilemmas. So, you know, which way do people go? Do they go to antidepressants or do they go to menopausal hormonal therapy? And often it just depends on which doctor they see. If they see a psychologist who sends them to a psychiatrist, they'll get an antidepressant. If they go to a gynecologist, they might get a hormone treatment. If they go to a GP, it depends on which talk the GP has been to recently. So it's really difficult. Sleep regulation is really critical because sleep is a big problem here. This is not a minor depression when it hits. It is a major depression. And perimenopause, and I'll finish very soon, perimenopause can be a 10-year or more process. So we cannot just say to the middle-aged woman, don't worry about it, it'll all get better once the menopause settles down. Yes, it might, but it might not. And also, we can't ask people just to hang on for 10 years while her life is becoming worse and worse. The quality of life, the quality of relationships. I've seen many women who've attempted suicide because they've lost relationships, they've lost their prestigious jobs because they're depressed. The concentration, the memory functions are not what they were. And so she goes down the tube and takes with her, as Rosemary said, women are the bearers, the rearers, and the carers in society. So, you know, you can't afford to lose the mother of teenage children in functionality or actually in reality. And so this is the issue we have to work with, is to treat properly. First of all, recognize and treat properly perimenopausal depression, because it is very treatable, particularly with a hormone approach. So I do have lots more, but I have run out of time, so I might just leave it there.
Thank you very much, Prof. That was very interesting, and I definitely have learnt so many new things just by listening to that. The first one is that the facts about the statistics on suicide. I was definitely one of those people who thought it was the younger men, but as you said, it's the older men who are affected by that. I had a question to start off, otherwise I'll leave it to the floor first to see if anyone had any questions. Great. Alrighty, I'll start us off then. So I was going to ask, in terms of the PMDD, it seems like such a big issue, but you're saying that there's still some cases where you're seeing that hysterectomies are being done, where you, was it last week or something, you had someone. Is it that it's not recognised amongst obstetricians and gynecologists, or is it that they don't know enough about it? I know we've already received a lecture on PMDD and that it does exist as a form of depression through our medical career, but why is it that we're still seeing those?
Yeah, I think you find that it's not very well recognised, it's not discussed very much, and so there's still a very large group of doctors in general from all kinds of different disciplines. It's not just you know, one discipline, but it's very, very common that we hear from women who say things like, oh, my doctor doesn't believe me. And again, also, you know, my family doesn't believe me because they think, well, you must be putting it on. You're really, you know, in bed bound for about 4 or 5 days, and then you bounce back and you look completely normal. You must be putting this on. So it's a very difficult concept for some people. And again, there's a weird sense that, you know, your hormones are really very much about reproductive health and not so much mental health, and that there's still a barrier there. So I'm glad you've had lectures, because we're hoping to get to our next generation of doctors early and I'm certainly doing that at Monash. But I've got to say, if I think back on my own medical training, nobody talked about PMDD.
Thank you for that. Yeah, no, it was recently in our psychiatry block where we had a lecture on to use that as one of the differentials in when taking a history, just to keep that at the top of your mind. Anyone else have any questions?
I had a question, if that's all right, Samira.
Yeah, go on.
Thanks, Prof Kulkarni, for the presentation. I'm just wondering how we can address some of the taboos in the general society level, because I'm sure there's a lot of women that don't even know that this is a type of depression. What are some of the ways that you've tried implementing or you suggest will happen in the future?
Yeah, well, I think we all have to do quite a lot of different lobbying at different levels. And I think this is where the general media are actually really good. So there was a couple of programs recently on PMDD, SBS Insight had one. And I think once you get it into the general media, then people go, oh yeah, my aunt or my cousin or my sister, yeah, that's what you've got. You know, that starts the conversation out there. And it's the same with menopause as well. And menopause is still the elephant in the room. We don't talk about menopause, and particularly not helped by older generations going, well, you know, stop whinging, get on with it. Every woman has to do this, get through this, don't make a big deal. So those conversations need to happen in the general media. We need to educate our medical fraternity more than our medical sorority, but you know, we've got to make sure that all of our upcoming doctors know about this and are absolutely aware and listening when their patients come in. That's another critical part about it. But I also think we need to get to our policy makers as well, which is why we talked about the, you know, the $1 billion loss, etc., because, you know, money talks, and we're trying to get some more policy recognition. So I'm very grateful for opportunities like this to reach, you know, whoever we can. And we do talk about this in different international conferences and so on and so on. So again, as the science becomes better, that also helps, because then it's not just a matter of belief or whatever. You've got the evidence base from the research to actually bolster that and to develop effective treatments.
Thanks so much.
Why talk about it? Really important.
Thank you, Sam. We've actually got someone from policy here. We've got Prof Ruth Stewart, who's the national, who'll be speaking to us next. So she can give us a few pointers based on that and give her opinion. We do have one other question here, which is from Dr. Elumelu. And he says, do you notice a lot of more incidences of COVID during the lockdown?
It's so sad. I have received last week, in 1 week, 368 referrals for new patients to be seen.
Whoa.
And my normal referrals from GPs and other doctors would be about 14 to 15 per week. So you can see what has happened.
Oh my God.
Yeah, it's just dreadful. And women in particular are worse off in COVID. For all the reasons that we talk about, there is an increased pressure in terms of the domestic violence situation. I've had some awful talks with, well, whispered conversations with women as they're in the toilet, because they haven't got any other place to have a conversation. You know, we've had to send in the police, get the women's refuges activated, and you know, it's just awful. So lockdown has affected women's mental health more. It of course has affected everyone's mental health, but the elderly and women in particular, and elderly women even more so. So again, I get very upset when people say youth mental health, youth mental health. Of course, we want to make sure our youth are healthy. Mind you, youth mental health has become synonymous with young men. So youth should involve young women, but young women's problems are different. And in this instance, we're seeing very, very escalated deliberate self-harm in our emergency departments, increased, huge rates increased. And that's because of the anxiety being taken in rather than out. We're seeing huge increases in women and alcohol, middle-aged women in particular, with red wine as their go-to anxiolytic. And of course, that then becomes a problem in itself. And we're also seeing elderly women just descending into major depression, often because they're on their own. They've lost their contacts because of lockdown with their other family supports.
Okay, thank you very much for that. As you've just finished that, someone else has sent a question. If you could quickly answer it, it's in the chat. So it says, who would actually manage cases of PMDD? Is there something a GP can do, like Prof said, for PMS and PMD?
Yeah, I actually think PMDD patients usually do go to their family doctor, and that's the best person to actually do something. Unfortunately, my colleagues in psychiatry are a little bit slow to take up the hormone and the organic side of treatments. And you can, yes, of course, everybody, can get some help from psychotherapy, but the key issue here is to utilize probably the contraceptive pill, provided there's no other medical complications that you're dealing with. But the OCP is probably the best way to start to actually stabilize some of the hormone fluctuations. And family doctors are brilliant at doing that. They do it for contraception. They can then follow up with making sure there's proper cervical screening and that the breast screening and all the other things are done properly. And so I think family doctors are in the best possible position to do that. It does, unfortunately, present as perimenopausal depression, so you can get the PMDD somewhat under control, and then unfortunately by the time the patient gets to the mid-40s, it all just explodes. And I work in a clinic with an endocrinologist. We see patients together, and my endocrine colleague said, it looks like perimenopause depression is PMDD times 40. So, that's a bit gloomy. But what we then tend to do is increase the level of hormonal manipulation by going to HRT, provided she doesn't have other complications.
Thank you very much, Prof Kulkarni. I think we'll leave it to that in terms of questions. Just that I can introduce our final speaker, who is Professor Ruth Stewart, who is the current National Rural Health Commissioner. So she was appointed in this position in July 2020, so very recently in the midst of this pandemic. And she brings to this role nearly 30 years of work experience as a rural generalist doctor with the advanced skills of a GP obstetrician. Ruth and her husband Anthony Brown now live and work on Thursday Island in the Torres Strait, so still in a rural setting. Amongst many other amazing achievements, Ruth achieved a PhD from Flinders University in 2014. Her thesis examined the lessons learned from a managed clinical network of rural maternity services in southwest Victoria. She has an abiding interest in quality of rural maternity services and sustainable models of rural healthcare. Without further ado, Professor Ruth Stewart.
Hello, can you hear me?
Hello. Yes, we can hear you.
Yeah, great. Okay, I'm going to ask you, Samara, if you can share your screen with my thanks, because I'm overcoming a couple of different technological challenges, but with Samara's help, we're overcoming them, so that's great. Look, I've put together a talk that focuses pretty much on the impact of rurality and remoteness, as well as Indigenous status on maternal and child health outcomes in Australia. And I begin by just giving you a bit of overview of who I am and what I've done. Samara's already given you a bit of that, but so we might rush through that part. But please ask me at any time if you've got some questions, because I've just chosen to put together these things, but I can talk about anything that you'd like to ask me about. So rural maternity care, why is it important to me? I often wonder whether the fact that I was born prematurely in a bush nursing hospital in northern Victoria has something to do with it. I was born at 32 weeks. I was delivered by a midwife and a GP obstetrician, and I seemed to do quite well. My background, I was educated in Victoria. I got an MBBS from University of Melbourne. I went to the UK to get some obstetrics experience, got a diploma of obstetrics back in the day when that was the relevant qualification. That's been converted to a DRANS diploma of the Royal Australian New Zealand College of O&G Advanced. That means that I can provide intrapartum care up to and including caesarean sections. Just a bit of a caveat, I haven't done, I'm no longer working clinically. Last clinic I ran was February last year on Muir Island, which is in the Torres Strait. So I trained as a general practitioner, and as Samara said, I've had 30 years as a rural generalist. I also got into medical education. I set up the rural program for Deakin University, worked with them from 2008 to 2012, and then I moved up to James Cook University, where I was the Director of Rural Clinical Training from 2012 to just the 30th of June this year. I am the immediate past president of the Australian College of Rural and Remote Medicine, and now I am the National Rural Health Commissioner. What's that? Next slide. So look, the National Rural Health Commission is a statutory role, and that means that the role has been created by parliamentary legislation. The role is independent of government, so both of the Ministers of Health and the Department of Health, but I am to work collaboratively with both. The job is to consult with rural and remote communities and key stakeholders in rural and remote health, and use the outcomes of those consultations to formulate advice for the government, so that is the ministers and the department, to assist them in developing policies and strategies to improve the health outcomes of rural and remote Australia. If you think that sounds like a big deal, you might wonder how I sleep at night. Sometimes I wonder, but this is the stuff that I have been passionate about all my life, and so it's such a privilege to be appointed to this position. As a rural GP, I often used to feel that with my education and my contacts, I could go and negotiate for my community in the halls of power and use the voice that I have for my community, and I am still doing that. Next slide. So I wanted to talk to you about rural maternity outcomes. Just as a thumbnail sketch, rural and remote families experience higher rates of maternal death. Rural women have significantly higher rates of neonatal death, and remote women have higher rates of fetal death. So, you know, in some ways, if you're wanting to have a safe experience of maternity care, it'd be better if you lived in the city, but not everybody lives in the city, and it's been one of the major challenges of my life to think through how we can improve the rural maternity outcomes for Australians. So sometimes people think that those poor rural maternity outcomes are related to the increasing proportion of the community that is Indigenous, the more remote you go, but that doesn't explain it all. In fact, it only explains a very small part of it. Next slide, please. This is one of the things. I just want to show you this slide, which I think is, this graphic is a neat description of of the lesser access that rural women have to maternity services, and how it has decreased in the past 30 years. In 1991, when I was pregnant with my second child, there were, I just need a little, I don't just talk about this stuff. I had 3 of my 4 children in a small rural hospital. And I can tell you it was a much better experience to have to birth in a small rural hospital for me than in a large quaternary maternity service in Glasgow, where I had my first baby. There was no way I was going to return to a large centre. The personalised care, the continuity of care was dramatic, and for somebody who had a very normal birth, it was a much better experience. And my children, the older children, could visit me on their way to school when I was still in hospital. They'd walk past the front door, come in, make a lot of noise, and I'd kick them out to get on to school before they drowned the baby in the bath or any of the other things that they were trying to do. Okay, so you can see that back in 1991, there were over 300 hospitals per, now what's the number? I'm lost it. So there were over 300 hospitals that delivered less than 100 births. By 2006, that had decreased to, thanks Samara, that had decreased to 150. It had halved. You know, what's with that? Then compare that decrease with, if you go right to the other end of the x-axis there, you can see that, in fact, the number of hospitals that had more than 2,000 births actually increased over that time. So women moved to much larger hospitals during that time. And I'll just remind you what I said about my experience. If you live in a rural and remote community, there's a number of studies and lots and lots of anecdotal evidence, reports that rural women want to give birth in their own community. They want to have their family, like I said, the kids calling in, their friends calling in. If you have to relocate, even if it's an hour away, let alone 10 hours away, 2 plane flights away, the people who matter most to you can't come and visit you at this really important time in your life. Women tell us that what they care most about in a birthing service is, yes, they care about safety, and they also care very much about relational care. They want to know the people who are caring for them. That's really difficult if you turn up at the place to give birth a couple of days before, even if you turn up 2 weeks before. Thanks. We'll go on to the next slide now. I'm looking at mine, wondering why. Okay, so now I'm just going to give you some population health statistics by remoteness. Let's look at this one. Low birth weight babies. I want you to look at that top row. Major cities, 6% of births are low birth weight. And as you progress to more remote, the percentage of low birth weight babies increases up to 9.7% in very remote communities, such as mine, Thursday Island in the Torres Strait. Now, why is it important about low birth weight babies? They're the ones who get sick. They're the ones that are much more likely to die. Sorry, that's 101 in maternity care. I'm probably telling you stuff you already know. Next slide. What about infant mortality rate? As I suggested, you can see the difference between major cities, the infant mortality rate in major cities at 3 compared with very remote at 7.9. That's nearly 3 times. I mean, it's 2.5 times. That's a really significant difference. And I ask, as a rural, now remote woman, I ask, how is that conscionable? Why should I, and why should my family, and why should my friends get less back on our tax dollar for the care that is provided to us and the quality of outcomes than somebody living and working in the major city? Okay, so let's just think about the impact of indigeneity. For Aboriginal and Torres Strait Islander women, there was 2 times the rate of infant mortality than there is for non-Indigenous Australians. I'm just going to let that sit there for a bit. I don't think that's okay, and I'm guessing that most of you here don't think that's okay. Now, though that difference was most marked in the Northern Territory, of the 5 jurisdictions that actually reliably identified indigeneity, it had the highest infant mortality rate. It was 13.5 in 2006 to 2008, and in a decade later, it had only dropped by 0.5. Okay, next slide. What about the child mortality? So the Closing the Gap report has a target to halve the gap. When it was first set up, had a target to halve the gap in child mortality rates by 2019. The report, that's not on track. Since 2008, Indigenous child mortality rates have declined by 10%, and that's not even statistically significant. Now, there is a caveat in this, that part of the gap is, when you're talking about a gap, you're comparing the child mortality rate for Indigenous and non-Indigenous Australian children. The non-Indigenous child mortality rate has declined at a faster rate than the Indigenous. So that actually, whilst child mortality rate for Indigenous Australian children has declined, the child mortality rate for non-Indigenous Australian children has declined faster. So there's still massive inequity. Next slide. What is the child death rate in Australia? Well, it's 146 per 100,000 for Indigenous children, and it's only 70 per 100,000 for non-Indigenous children. It's a gap of 76 per 100,000 if you need that. And that's a rate ratio difference of 2.1. So Indigenous children were 2.1 times as likely to die during early childhood as non-Indigenous children. So, but it's not all doom and gloom. There have been improvements. So the proportion of Indigenous mothers who attend antenatal care in the first trimester has increased from 41% in 2010 to 60% in 2016. Now that's significant. There's been a smaller increase for non-Indigenous mothers, but you'll note that back in 2010, it was for non-Indigenous mothers, it was about what it is now for Indigenous Australian. And this is one thing where there's quite a nuanced variation with rurality. If you are an Indigenous woman living in inner regional areas, you're more likely to access antenatal care compared with women in major cities and very remote areas. Now, if people are interested, I can talk a bit more to that later, but let's just move on to the next slide. There have also been improvements in the proportion of low birth weight singleton births. So for Indigenous mothers, there was a slight decrease from 12% to 10.2%. Every little bit helps, but we wanted to see a lot more improvement. But that is a more significant improvement than it has been for non-Indigenous mothers who really have a very low birth weight, low proportion of low birth weight singletons. Next slide. And that's the end. Okay, so let's just swap back to if we can stop screen sharing now.
Yes, I can.
Yeah. Okay. So look, I wanted to show you those figures to suggest that if you are wanting to really make a difference by your working life, there is a very big difference to be made by working in rural and remote Australia, and by working in Indigenous communities in Australia. We are making headway, and you might guess by the fact that I live in an Indigenous community that this matters a lot to me. Thursday Island has actually seen much greater improvements than those across the nation. And that's because we have paid a lot of attention to, well, not just Thursday Island, the Torres Strait and Northern Peninsula areas of the pointy bit of Australia. That's Cape York Peninsula. So the Northern Peninsula area is the tip of the Cape, okay. By providing a midwifery-led continuity of care model where there is a known midwife for every woman, with strong cultural safety within the model, we now have an exceptionally high rate of women who have antenatal care from early in their pregnancy, and the proportion of women who are having low birth weight babies has really decreased. So we know how to do this stuff. It's just getting the word out about how it's done, and also having the commitment. So there's a difference between policy and implementation. So there are policies that support this. I've referred several times to the Closing the Gap initiative, which you'll be, I hope you'll be familiar with. And it's having variable impact. It was substantially rewritten this year to have much more hands-on and with more practical approaches. Now, I've said I'm a GP obstetrician. If you're wanting to make a real difference in rural maternity outcomes, you would follow my lead and become a GP obstetrician, because specialist obstetrician, Jacob, could you work on Thursday Island? You could, but you couldn't live here and do all of your work here, because there wouldn't be enough work for you. That's really what I'm meaning. Yeah, I know you're on mute at the moment.
Yeah, it depends on, because I do a lot of stuff. So. Actually, in another life, I trained as an ED specialist, so at times I slip into those roles. But general psychiatry, yes, but not. This is only a tiny bit.
Yeah. Look, On Thursday Island, we have a rural generalist model of care. So first of all, you have to be a primary care physician, general practitioner, with a special interest. So if you wanted to train in general practice and come and join us, you would be most welcome. We certainly have a great need for...
Gabrielle Casper here. There are a lot of doctors from Nigeria listening to your talk. Could you tell them what the population is and what care is available on Thursday Island? It's not high on the agenda of our Nigerian doctors.
No. Hello, Nigerian doctors. In 1984, I spent 2 months in Ibora in Oyo State at the rural healthcare centre there. I was doing a rotation to Ibadan University, and I still have some Nigerian friends. Yes, what am I? And why I mentioned that was that it was a very great surprise to me to go to a rural area and find that, for my Australian sensibilities, it was a very crowded space. In Australia, when we talk about a rural community, you would expect to go outside a town and be able to walk for an hour without expecting necessarily to see anyone. I learned very quickly in Nigeria that I don't remember any time where there wasn't, several people in view wherever I went. And we went to some quite remote clinics from Ibora. Thursday Island has a population of 2,500 people. The Torres Strait, which is the archipelago of islands between Australia and Papua New Guinea, has a population of about 12,500 people. Most of the people in the Torres Strait are Torres Strait Islanders who are Melanesian. But as you move onto the Australian mainland, the pointy bit of Australia, as I mentioned, there are Aboriginal Australians there. So, and many of our families identify as both Aboriginal and Torres Strait Islander. But the two are very different cultures and behave and have very different cultural practices and ways that they interact with healthcare. But as my Nigerian friends pointed out to me in 1985, the Australian Indigenous peoples have much less access to our run-of-the-mill healthcare because of all sorts of cultural reasons. Yeah, and I'm very happy to take any questions, and I'd love some questions from Nigeria.
We've got one in the chat, Prof Stewart. So there's one from Dr. Elumelu.
Yes. So the question, could it be economic, cultural or social factors? Look, we know it's actually a combination of all of those as well as access. And the cultural stuff is one of the reasons for lack of access. We know that if there's been a number of studies that show that if you provide a culturally safe antenatal service for First Nations Australian people, they are much more likely to attend for the antenatal care. But I see that your question is actually about all of the health indices, and yes, the social determinants of health play a very strong role in Indigenous health in Australia. Although, the health outcomes are worse in remote communities, as is the housing, access to fresh food, and access to healthcare. Yeah.
Thank you. I was just gonna bring along, ask the rest of our audience if anyone else had any questions for you. If not, I have one. So I was going to ask in terms of the close the gap. So from your perspective, what do you think is one of the major things that has led to not being able to close the gap and most of it not being met, most of the targets not being met?
I think
could you define again for the Nigerians, when you talk about close the gap?
Oh, yes.
What does that term mean?
Okay, so the phrase close the gap comes from a report into Indigenous Australians' health that was published in, I think the first one came out in the mid-2000s. And it identified that there are significant gaps in the health outcomes for Indigenous and non-Indigenous Australians, such that if you are an Indigenous Australian living in a remote community, your life expectancy if you were a male was 27 years less than if you were a white Australian living in a large urban centre. And that is a national shame. The Close the Gap initiative, as it has been called, as it is now called, is a whole raft of policies aiming to close that gap in health outcomes. What do I think are the issues? I think that there's inertia. I saw a poster on the wall in an office kitchen recently that said everybody accepted that there was lots of dirty dishes. Anybody could have washed them up, but nobody did. Somebody was going to do it, and I think it is a little bit the same with Indigenous health. It requires a whole of community and whole of government response. One of the things, the Close the Gap initiative absolutely recognises the social determinants of health, that if you want people to be healthier, you need to give them equal access to education. You need to give, they need to have similar economic advantages to the rest of the community. So they need employment, and so education, employment, housing, and access to clean water and good food. Now, I'm guessing that the Nigerians would think that that happens for everybody in Australia. Well, it does if you live in, if you are wealthy and live in urban centres. It's pretty good even if you're poor living in an urban centre in Australia, but the poorer you are and the more remote you live, the more difficult it is to access good housing, good food and clean water. Clean water is probably the better of those, but you know. So I think that's one of the issues that we need to see concerted effort to improve the learning outcomes for Indigenous Australians and the housing. I'm not convinced that there's been very much movement on the housing for remote communities. I think that we can see by looking at the last 10 years that those health outcomes that you know get a faster response, and those are birth weights of babies. There has been some improvement. The antenatal care, there has been some improvement. And so the long answer, I'm sorry, Samira. I think that it you know, needs more coordinated and coordination and sharing. And what's it come down to? If this was an attractive white girl living in, you know, in an urban centre whose baby died because she didn't access antenatal care, there'd be a lot more outcry. I think that there is, that Australia has still, you know, a deep level of racism.
Yes, thank you for that. Anyone else have any questions for our three fabulous speakers? Yes, we have Odelia, would you like to ask your question?
Hi, Professor Stewart. Thank you so much again for your presentation. I just had a question regarding, you mentioned that there's been a significant improvement in the statistics for women receiving antenatal care. So 2 parts of the question was, how did you achieve this? And then secondly, like because you do have an extensive amount of experience and whatnot, what do you think is the best way to continue to improve these numbers?
Okay, so I mentioned, so you need to make antenatal care something that women see the advantage in. And if you talk about, oh, I need to check your baby's heart rate and I need to make sure your baby is growing, that might not mean as much as saying, you remember your auntie's baby that died when you know, her tummy wasn't very big? If she had come into the hospital, we could have heard the baby's heart rate wasn't good and we could have looked after her and looked after the baby. And establishing relationships so that it's a fun place to come. You just, if you haven't lived in a remote community, if you haven't shared, stories, life stories with Indigenous Australians, we as white people, there's so much we don't see that happens. One of my sisters worked in Koori education in Victoria. Koori is the Victorian word for Indigenous families, and she went one day with one of her students to the post office, and her student had very dark skin, and they were waiting in the queue, and people just kept passing them because the woman behind the counter called the other people forward. And my sister got really cross about it, and her student said, Kate, be quiet. No, Kate, be quiet. This is what happens to us all the time. And Kate was horrified to realise that she had queued in that post office over and over again. And she had been working with Koori students for 15 years, and she had never noticed that that's what happens. And so why am I telling you this story? There are all sorts of small things that might happen in an antenatal clinic that if you were Indigenous, you would get a message, you are not welcome here. We don't care about your outcomes, and you are not respected. Now, it's interesting, the things that make a difference. They can be very small. They can be, well, very small. A big thing like Indigenous artwork on the walls, and an acknowledgement of the traditional owners in the public space, treating elders with respect. So if your grandmother comes in with you, saying, hello, auntie, welcome, rather than saying, are you the mother? Or, you know, would you mind sitting over there? Because it's culturally, very often the auntie is the most appropriate person to accompany a young pregnant woman on her journey through the healthcare system. And you know, the bottom line is have co-design of your antenatal clinic with the people that that you're wanting to use it. Ask them. That's a radical idea, isn't it? Ask them what do they want, and listen to what they say and respect it.
It's just following on to that, Prof Stewart, it's interesting, one of the questions we just got is from, where is it? From Ibe Chinedu, who says, thank you very much, Prof Stewart. Who are these non-Indigenous people? Who are they, the immigrant population? I wonder why the natives are disadvantaged in terms of access to essential healthcare.
Yeah. Oh, wow. I could talk for hours about so bless you. That's such an excellent question.
Yeah.
I pointed to myself. I am a white Anglo-Saxon woman, descendant after 5 generations of migrants from Scotland, Wales and Ireland, and who arrived in Australia for the gold rush, joining a white community that had disinherited the traditional owners of the lands of Australia. There is a big debate in Australia at the moment. I don't actually see why it's a debate, but it is about acknowledging that that Europeans took land and there was a widespread genocide of Aboriginal and Torres Strait Island, Aboriginal people. Torres Strait Islanders, I've mentioned the fact that they're very culturally different. The genocide, I'm not aware of any massacres in the Torres Strait, apart from Torres Strait Islanders killing each other. They were headhunters, and white people were pretty scared of them. There are plenty of stories of white people being killed by Torres Strait Islanders. It is no accident that the first successful land rights claim in Australia was from Muir Island in the Torres Strait. Torres Strait Islanders are proud, assertive, and have been less subjugated than Aboriginal people. So not only was the land stolen, which has a deep cultural and spiritual significance for Aboriginal people, the children were stolen, the people were made to live in what were called missions, and there were massacres. It goes on, and but there is strangely debate in Australia as to whether that occurred when there is ample evidence in our official records of this happening. Yeah, it's our shame. It's our deep shame.
Unfortunate shame.
And to be honest,
and
I have experienced.
Yeah.
Sorry, I was just going to say.
Oh yes.
This has been my life journey. When I went to Nigeria in 1985. People said to me, "You Australians, you are really racist. Look what you've done to your Aboriginals." And I was sort of, really? And yes, that's been my life journey, coming to a deeper understanding of that.
Yes, thank you very much, Professor Stewart. And for all our speakers tonight, I think we have been enlightened in many different ways. We initially had Prof Ogu, and then who was giving us the Nigerian and the World Health perspective, and then we had Prof Kulkarni from Melbourne and telling us about the mental health crisis we're currently having, especially with women. And then finally, Prof Stewart, you were telling us about one of the biggest problems we have here in Australia, which is that differential between the Indigenous and the non-Indigenous populations. With that, I would like to thank you all very much for giving us your talks and giving us your time, particularly in these times. And I wish you all well and keep safe, everyone. Thank you so much. Thank you.
Bye.
See you.